I want to thank Mallika for having organized this session, and also the Scientific Committee of All India Ophthalmological Society for giving me this opportunity.
Dr. Shrinivas?
Any problem? This topic is now being discussed. Earlier, I think when I started retinal detachment surgery, those days only scleral buckling was there. And for good years, we did only scleral buckling. But then with the advent of primary vitrectomy, the things have changed. What is the principle of surgery? Any surgery you do, the basic principle of surgery, whether you do intestinal surgery or eye surgery, is this minimal surgery with maximum result. We want to destroy the minimum tissue and we want to get the maximum result. Let's see how it works for the retinal detachment. What are the problems were associated with scleral buckling? The problems are that, when you pass the suture, then you may perforate the globe. And there are chances of course, not now. We don't see any buccal infection nowadays with the, the advance in the technique and the sterility which is maintained. And those days when you used to do diathermy, there used to be more infection. And with the, this external drainage, mainly the problems are associated with external drainage in the form of, you may, go on, hit the vitreous, and you may, take bite from the retina, and there may be a iatrogenic retinal hole. Possibility of vitreous and retinal incarceration is always there. So there are certain, group of patients where primary vitrectomy is a good option. I'm not totally advocating for primary vitrectomy, but there are situations where primary vitrectomy could be done. Now, what are the indications of primary vitrectomy? If you ask me, for retinal detachment where the PVR is less than C1, and retinal detachment with superior plaque, these are the cases where primary vitrectomy works very well. And you may extend it to, of course, we do all primary vitrectomy for macular hole, but for inferior breaks, with greater than C1, maybe, you can use primary vitrectomy with encerclage. That could also be done. But of course, you are doing a buckling here. So for all cases where there is an inferior break with PVR greater than, C1, in those cases, a buckling along with vitrectomy could be done. Or else, if there is no PVR, of course, there only buckling will do. We did a small study, of course, we did in RP Center, and this was a randomized prospective clinical control trial of 61 phakic eyes, and the patients were followed up for 6 months. This is a primary vitrectomy, 23G, in which there is a superior detachment. And, this is the Alcon trocar and cannula. There are various trocar cannula available now these days. And this is a pseudophakic eye in which I am doing pseudophakic eye. And of course, you make 3 ports. And all such cases where there is a single tear and there is a superior tear, if you are doing a vitrectomy and if you have done a good, vitreous, this thing removal, and of course you have lifted the highlight, then in those cases you can, do a vitrectomy, and after that you can, do a endolaser and then inject the gas. This works very well in such cases. So you go inside, do the vitrectomy. There's a bullous detachment there. to remove all the, the vitreous attachment which is there. And then you drain. Mallika has already told me to keep time. There's a tear there, you can see. And then you drain the fluid, the soft tip cannula. Do the air fluid exchange and do the endolaser. I don't want to take much time. This is the 23G PPV with gas SF6. You can see the line of the gas which is there, and this is the one which hinders the vision in the early postoperative period. This is with SF6. And this, if you can see here, both the groups, vitrectomy group and the buckling group, the causes of failure are almost same. The final visual acuity achieved in these cases are also same. There is not much difference between the two. And if you see the, the duration, with the duration, the visual acuity is better in the buccal group as compared to the vitrectomy group, basically because you have injected the gas, and the gas, hinders the vision. But final visual acuity in both the groups are same. So anatomical and functional success rates were comparable in both the groups, and the visual acuity at 1 week and 1 month follow-ups were significantly better in the buckling group, for the main reason because if you inject the gas, definitely the visual acuity will not be that much good. And this is the scleral buckling, this is the post-pre-op, this is the post-op. And therefore, in cases where there is a single tear and the PVR less than C1, the 23G is less traumatic, and there's a quick surgery and the quick recovery is there. The good postoperative time outcome is there in both visual and cosmetic also. And there are no chances of any complications which we normally encounter with the scleral buckling surgery. And this is the surgery. I don't want to show you because you don't have time. Thank you very much.